Hyponatremia is one of the most frequently encountered electrolyte disturbances in pediatric practice. Understanding its causes and clinical manifestations is essential for nurses to recognize early warning signs, prevent complications, and support timely management in hospitalized children. Hyponatremia is defined as a serum sodium concentration below 135 milliequivalents per liter. In children, it usually reflects an imbalance between water intake, water excretion, and sodium handling, rather than a primary sodium deficiency. Because the developing brain is highly sensitive to osmotic shifts, hyponatremia carries significant neurological risk. The clinical impact of hyponatremia depends on its severity. Mild reductions may be asymptomatic, while moderate to severe hyponatremia significantly increases the risk of neurological manifestations such as seizures and altered consciousness. Nurses must correlate laboratory values with clinical findings. The duration of hyponatremia is clinically important. Acute hyponatremia develops rapidly and allows little time for cerebral adaptation, making children more vulnerable to cerebral edema. In chronic hyponatremia, adaptive mechanisms reduce brain swelling, but sudden correction can still be dangerous. Serum sodium is used clinically as a surrogate marker for plasma tonicity. Tonicity is regulated by antidiuretic hormone and thirst mechanisms. In most children, hyponatremia indicates hypotonicity, but nurses must be aware of exceptions such as hyperglycemia and laboratory artifacts. Most pediatric cases of hyponatremia are hypotonic in nature. This results from an excess of free water relative to sodium. Clinically, hypotonic hyponatremia is best classified based on the child's volume status, which guides nursing assessment and management priorities. Hypovolemic hyponatremia is commonly seen in children with dehydration due to gastrointestinal losses. Volume depletion triggers appropriate ADH release, leading to water retention. If hypotonic fluids are administered, serum sodium may fall further, highlighting the nurse's role in fluid selection and monitoring. In euvolemic hyponatremia, total body water increases without obvious signs of volume overload. The most frequent cause is inappropriate ADH secretion. Conditions such as CNS injury, pneumonia, and certain medications can stimulate persistent ADH release, resulting in dilutional hyponatremia. Hypervolemic hyponatremia occurs when total body water and sodium are increased, but effective circulating volume is reduced. This leads to persistent ADH release. Nurses often observe edema, reduced urine output, and dilutional hyponatremia in these children. Not all cases of hyponatremia reflect hypotonicity. In hyperglycemia, water shifts from cells into the extracellular space, lowering measured sodium. Pseudohyponatremia occurs due to laboratory measurement issues in hyperlipidemia or hyperproteinemia. Nurses must interpret sodium values in clinical context. Clinical manifestations result from cerebral edema caused by water movement into brain cells. Rapid declines in sodium produce more severe symptoms. Early recognition of subtle neurological changes by nurses is critical in preventing life-threatening complications. Nursing management focuses on accurate assessment of volume status, close neurological monitoring, and safe fluid administration. Preventing overly rapid correction of sodium is crucial to avoid osmotic demyelination. Nursing vigilance plays a central role in patient safety. Please like, share, and subscribe, and leave your questions as comments.